Thanks, Dr. Traynelis, for joining us. For our fellows, you may or may not know that Dr. Traynelis was my fellowship director, I guess 7 or 8 years ago now. And he's a professor of neurosurgery at Rush in Chicago, specializes in all things cranial and cranial cervical junction, and so forth. And was a great mentor to me, and certainly knows more about complex cervical than most of us will ever forget. Or he'll forget more than most of us will ever know, I should say. Trey, I really appreciate you making the time and helping us learn and helping our fellows learn. And take it away, man.
Okay, thank you. Since I had a little glitch signing on, I'm going to go a little quick through some of this that may be pretty basic for you. Here are my disclosures. And these are just some alignment parameters. There's more and more, but pretty much this is what I use. And we're talking about assessing basically just the cervical region. And I especially like the T1-C2 slope, because if you really have a markedly abnormal SVA, I can help use this to help me decide, do we want primary correction below? We look at many other factors, or do I want to start in the neck? And lordosis is easy to reproduce, widely known. And now more and more focus on SVA, and I'm one of these people, but it's just a number. Look at this person with an SVA of 92. He has 0 neck pain. So we have to realize it's just a number. But the main focus I want to make is that kyphosis is bad for us. It causes myelopathy by this compression, increases intramedullary pressure, you lose neurons, demyelination occurs, blood supply is affected, leading to apoptosis. And we know that this is bad when we look at staining films and such, but this interesting study, they measured focal kyphosis on an MR. This is a supine film, and found that this was significantly associated with myelopathy, and even more so than the abnormalities they saw on upright and dynamic x-rays. And so kyphosis is not what we want. And if we're going to talk about deformities, the most common cervical deformity is a degenerative deformity. These are glacial. It starts with loss of lordosis and then becomes kyphotic and have translation. And here we have both global and focal. And so this has both of the bad actors. And if this patient has myelopathy and or neck pain, and we want to treat it, we have to address the deformity. And so our goals: decompress neural elements, optimize alignment, rebuild it as best we can with the least complications. And so for me, if we're talking about this, we've defined a patient we believe needs this reconstruction, then we can do it solely posterior, solely anterior. But either way, it's going to be multiple levels. So I'm going to start out and just make a few statements about what I think about with multiple levels. I use a longitudinal incision. I've tried multiple transverse incisions, and I find them cumbersome. I always go on the left because anatomically, despite what the literature says, we know anatomically the recurrent laryngeal nerve is less likely to be aberrant. And here is an aberrant, the only one I've seen in my life, recurrent laryngeal nerve crossing the right space at C5-6. And if I would have had to go down and get this level, it would have been a problem. So I like the left side. I section the omohyoid because I believe this frees the tracheoesophageal bundle, decreases the risk of dysphagia. And I take the arteries. I clip the arteries if they're in my way, superior, inferior thyroid arteries. If you have a big exposure like this, you do need a table-mounted retractor because the self-retained retractor is just, the tissue's too loose for them. I undermine platysma ever. If I want to go rostral or caudal, even with a transverse incision, I just go up and I tee the platysma in the direction I want to go. And so we're going superior thyroid artery, usually crossed around C3. I only clip about 2/3 of these if I'm going up there. So sometimes you can just kind of work it out of your way. The facial vein, I used to put clips on them, but I've had some clips fall off. It's not a lot of tissue, so I pass a suture around them, and then I stab the vein and I tie the suture to the vein and divide it. So now my suture can't fall out. And so the large veins, that's how I handle them. You look in the literature, people talk about the digastric tendon, the submandibular gland. I've never seen anything like that. When you hit the superior thyroid artery, you have to worry about superior laryngeal nerve. branch of the vagus. It really has bilateral overlapping sensory innervation, and it innervates a small muscle that is important for voice pitch and perhaps projection. And if I lost mine, I would never know it. And so I haven't seen a problem in any of my patients, but that doesn't mean I haven't had this happen to them. I think they're just not high-end users if it's happened. And then going low, often I just take the inferior thyroid artery. Twice in my life, I've seen some milk oozing from the wound. And these were both with accessory thoracic ducts. And you can see it. It's real. You can't coagulate it. You can't do much. I get little tiny microclips and I try to bunch the tissue up around it and seal it. And I've been fortunate and it's worked for me. And it can be difficult to get low. Sometimes you can figure out if you can get there easily on an X-ray, CT. It's more precise. MR can show you soft tissues better, especially the arch of the aorta, which is really going to limit you. And we'll skip this. I'll refer you to this article by Ozdrubal where he walks through sort of a little algorithm about whether or not you need to resect part of the upper manubrium. So once you're in, I resect all posterior osteophytes, posterior lateral. Pins, if you have a nice young person, you can do this. If it's one of these spines, you can do that. And so I usually get into the inner space and I work with bilateral interspace spreaders laterally where the bone is dense. And we both turn these at the same time. If it's a really deep wound, both the Bryan and I believe the ProDisc C retractors, which they're not marketed anymore, but these are big, wide, strong retractors that you can get in the inner space and really help force it open. And then putting the screws C2, C2 can be a little troublesome. So you have to pay attention because that if it came in from the left here and I'm trying to get that, that's the contralateral screw and I got to really move the tracheoesophageal bundle. You think you get started and you can slide down the side. So it's just something to keep in mind. And it's led me sometimes just to use a self-drilling screw there, like just angle it and then tap it and put it in. But C2 can be a little narrow. You should adjust your plate to be flush with the vertebral bodies. If your reduction is incomplete, then you're going to have to make some kind of contouring, but you want that plate abutted against the bodies. And if you really loosen things up, you can use your anterior instrumentation to help you. And I'll show you a few cases. This isn't really a degenerative one. This is a lady with a young woman with bilateral pars defects, and of course she's super loose, so the plate's bowed. So you want to start in the middle because as you pull the spine to the plate, you want it to be able to come up. You don't want to lock the rostral caudal end with screws and then try to force the center up and it'll compress the discs and such. So you can pull it up. We all can do this and just a illustration that you want to start in the middle and work the spine toward you from the middle because its relationship with the rostral and caudal ends will change as it comes into lordosis. Lateral, posterior limit dissection. If I'm going to do a laminectomy with this, I always drill my holes first, put in my pedicle screws, then I do the laminectomy, usually with a foot plate. Then I put my screws in, and then finally I lift the lamina from the dura. If you line up your screws, your life's a lot easier. If you have a problem with the lateral mass and you really blew it out and you want to get a screw in there, you can salvage it with a transarticular screw. And I have an illustration of that. But I like crosslinks. And unlike in the thoracolumbar spine, they don't say fusion. If you're going to do a front back, it's going to fuse. So taking up a little space on my rod doesn't bother me. But be careful. If the crosslink's at the CT junction where the skin is so thin, there's no soft tissue coverage like I did here, that had to come out eventually. So don't put them unless you have a good muscle fascial coverage area. And transarticular screws, you can put them in perk, but if you really damage something, you can cross that space with these. So first case, 67-year-old woman. She claims she had abrupt weakness, no pain, neurologically okay, no major medical problems. Here she is, flexion. She's already flexed. That's the best extension she can get. And so if we look at the slope thing, we have 30 degrees T1 slope, 80 degrees C2 scope. Of course, it's obvious to look at, but sometimes it's not so clear to you. But look at this CAT scan, she lines right back up. She's got some sort of axial muscle issue. And if you wanted to do something for her, since she does line up so well, facets are not ankylosed, you can do not great, but pretty good by just going from behind. And so that's an example of behind. Here's a lady, she is mobile. She can't fully reduce, but I know she's mobile, and I'm not showing you the CT, but the facets are free, so I can go in the front, take out the uncinnates, crack open each one, and then she gets backed up from behind just because of the length of the surgery. So this is what I would use as a brief example of what I might do a front back. And now it gets a little more messy. This lady's had previous surgery, T1 slope 26, C2 slope is 67, 68 almost, 36 degrees kyphosis across there, and an SVA of 70. So, and she's miserable. So we obviously have a problem. The CT is extremely helpful to me, both coronal and sagittal. So I want to see what do the facets look like, which here, of course, some have had surgery, but even if they haven't, I'm going to focus on that. So she's pretty straightforward. Posterior releases. I then do the correction from the front and back it up. And it's not great, but pretty good. But time humbles you. And as the months and years go by, she starts to fail from below. And this is something I've seen only with patients that have had a posterior procedure, whether solely posterior or front and back. And so this can happen, and this is one of the great problems with these long posterior constructs. And here she is. And part of her issue is uh, that she's got this, and she's trying to fix this terrible lumbar stenosis. Her main complaint is low back pain and claudication, but nonetheless, she fell off, and a lot of these people do. And we've had enough of them that we've been interested in it. So we're not only studying our own experience, but we're looking in literature to try to do this meta-analysis. And really a lot, when they fall off, I send them to my partner, Ricardo Fontes, and it's his problem. So he's also keenly interested in this. So here's our meta-analysis. And if we look at that, and I know we have stalwart ISSG leaders present, but if we take out the ISSG, this is all we have. So the ISSG has given us great volume of literature, but there can be, from a scientific perspective, a concern that it's a select population, those patients that this group treated. Nonetheless, if we look at what are the risk factors for falling off, and we have pre-op lordosis, pre-op SVA, post-op SVA, change in lordosis, osteoporosis. And so if we go through this, there's a lot of things we have zero control over. If we're going to have to do more than 4 few levels, we have to. We don't control the preoperative numbers. But one thing is post-operative cervical SVA. Although maybe 40 is a target in the literature, if we look at this, maybe if we're going to correct someone, we need to do better than 40, because here, once we got over 35, we saw a drop, at least in these studies, in increase in distal kyphosis. So, couple other cases. This lady, 75, terrible neck pain, feels like her head's falling off, very thin, markedly osteoporotic, keeps falling, had a femur fracture. And here's her radiograph. And so how do I think about this? So I see this. You see it's pretty stiff. Look how she's bunched up at the craniovertebral junction. She can't even relax that. And then on the MR, we see some ventral cord compression. And so this could have something to do with her gait problems and falling. And overall, not horrible. And so the key for me here is, what does the CAT scan tell me? And so I study both these midline sagittals, but I want to see the parasagittals, and I'm going to detail every facet. And sometimes a facet might look fused, and when you get in there, it isn't. So I want to see what the facet looks like, and I also want to see what the uncinnates look like. And so if I say, okay, well, if I didn't have this uncinate problem, maybe I could go from the back. And if I wanted to be aggressive and get in pedicle screws and free up all the facets, maybe I could fix it. But it's going to be really hard to do with this uncinate ankylosis. So summary, what the CT shows me is here. So these are all the things that I'm going to plan and I'm going to think about. And that's going to lead me to decide if I'm going to fix this, I'm going to fix it. I'm not going to go part way. And so she had a back, front, back, and here's how it turned out. And still not great. SVA doesn't look very good. I don't have the number here, but better, but not great. Big correction in thoracic cervical lordosis from 18 of kyphosis to 9 of lordosis, but still, maybe we should do better. And so many years ago, I started making my own hyperlordotic graphs. And I use these jigs, and I can make 15, 12, 5, and 10. And so after a while, I just marked on 12.5. And as you get in the market and you get out in the world and you see these hyperlordotic cages that are being sold as the answer, I just share with you that it's not really the answer. So here's one of my 12.5s in here, and you see what I call the air gap above that graft. And it can settle down with time, but it doesn't always. Now, how much can we get from a graft? We did a study years ago. So these are 6-degree cornerstones. And basically, if you put a 6-degree cornerstone in, you can get about 4 degrees for one level and 8 degrees for two. So you don't get everything you think you're going to get to begin with. I released these levels back then. I didn't over-distract because we know it's associated with adjacent segment disease. I put this plate in snug and contour, and here's a Korean paper, and it's the same sort of idea. If I get my grafts in here and I contour my plate, I can sink them down. But does it really happen? See, here's a plate in the surgery. So on the far right, I'm sorry, is the pre-op. Then the middle is that little air gap. Never got it down because of this. Those coronal facets are hitting each other. They're not going to let me fix this. So with that in mind, I say, okay, well, maybe I need to be more aggressive with facets. So here we have this fixed posterior post-laminectomy kyphosis. I have all my numbers. She got bad cord compression. I'm going to fix it. And so now, even though the facets aren't that ankylosed, my new strategy for something like this is as follows. I'm going to aggressively take out those facets. I'm going to leave enough to get lateral mass fixation, but I'm really going to take them down. So now I can flip her over. I can start a correction in the front. Here we are a little bit more. I'm getting good lordosis because I took out those facets. And so now we got SVA 42. I'm getting closer to 35. I'm getting better correction. And so I think that and it seems like a lot, but I think it's less risky than a T2 PSO or a VCR. And actually that's to treat a different problem. This was a mid-cervical problem. So it seems like a lot of surgery, and it does take a while. It's a long day. But I think that's now where I am with my own grafts and being more aggressive posteriorly. So those are my thoughts. And of course, all these, you get this fixed, they're happy people. And so there's a lot of strategies depending on what your pre-op assessment is. And these are just some of the things I think about and a few of my techniques during surgery. And I thank you for your attention.
Appreciate it, Trey. That's great, man. I want to ask you one question just dating back to when we were together.
Uh-huh.
You used a lot of I think they're called facet lift, those facet allograft spacers to try to augment the fusion in the back.
I did.
I've started to do that in some select cases. I know that there's sort of an intuitive concern about kyphosis. Can you just speak to that for a moment?
Yes, I'm trying to unshare my screen here.
That's all right. Looks like today's not going
Maybe
to
I
be too
can.
bad.
All right. So we did actually, I didn't do it. David Strauss and a resident, Lee Tan may have been involved with it too, but David Strauss, many years ago, I had that concern. It is parallel this direction across the joint. And we did a study. They took a year's worth of my patients that had only posterior surgery, first virgin surgery with the facet lift, instrumented fusion. So there were 45 patients that fit that criteria, and they measured a number of preoperative lordotic and parameters and post-op. And my technique, if there's a decompression, I would start inflection. Once I got the cord decompression done, we used to rearrange the Mayfield, but now I do them in a levo and I pull them back and then I lock my screws down. So I thought I was doing a good job trying to even improve lordosis, but lo and behold, doing this, the lordosis, the number was the same going in as going out. We didn't make them worse, but we did not make them better. And so I think that it's if you pay attention to what you're doing, they're really not going to hurt you. And I still do use them, maybe not as much as I used to, but I use them in a lot of situations. As you know, at C4-5, I always use them. I like working in the C1-2 facet joint, and so I still use them.
Yeah, I like C1-2 as well.
Tons of great pearls in there, Trey. Thanks so much for sharing. So can you maybe just speak to the technique of when you do your facetectomies? Are you doing like taking the inferior articulating process down and then just a little bit of the superior, or are you taking the whole superior? Like are you like skeletonizing all the nerve roots, or
so I have gradations of this. I used to do what I call posterior release. If I thought maybe there was just a little something there, sometimes I would use those facet shim grafts that go up to 4 millimeters just to take out all the cartilage and things. But now, if I'm going to go posterior, I'm going to do one of two things. If I'm going to do a real release, I'm going to open up the joint, then I'm going to take away the inferior 3 to 4, maybe 5 millimeters of the inferior facet, and then that drops me on the superior facet. I'm going to do I'm going to come right down on that. I'll be on the root, and I'm going to make sure I get that you disconnect that little wedge that gets up underneath the inferior facet, and I make sure I get that out.
Okay.
So that's the standard release. If someone's ankylosed or there's really severe foraminal stenosis, then I'll do what I call complete facetectomy, and this is pedicle to pedicle all the way out. Everything's going to go. So those are the two ways I might do it. And if I really want to correct a segment, especially if it's 4 or 5, and I'm really going to change the alignment there from kyphotic to lordotic, even if pre-op they have nothing, they're getting a complete facetectomy. I don't want anything crunching down on that root when we correct from the front.
Okay. Yeah, neurology first, right?
Yeah.
And then do you use a burr to do that, or what's your tool of choice to take your facets down?
I use a match head burr. I use cutting burr. I very rarely use diamond. I use diamond burr to start holes to put screws in. That's what I use diamond burr for. I tried many years ago. No, because it's slow. I think it's slow. I think you take a high-speed match head and you can take the shell off an uncooked egg without violating the egg. It's if you have the touch, it's efficient, and I think safe. I tried the bone scalpel, and I didn't give it a fair try. It's been a number of years, and I did it only on a couple cases, and I just didn't have a good feel for it. And if I'm teaching people, they put in there, and I don't have their feel. If I watch them with a burr, I see what it's doing, and I can guide better. So for those reasons, I stuck with a burr.
Makes sense.
We're going to start making the fellows try to drill the shell off an egg.
You can do it. I'm telling you.
I like that, actually. Yeah. Sounds like interview season next year, Hanny.
Yeah, buddy.
Well, Dan used to have me. Dan used to have me take the burr and put it on the spinal cord and burr just to prove to me that it won't cut it.
Oh, geez.
Oh my gosh.
I think the only way you can get in trouble with the dura is if you hold it there for a while. As long as you keep it moving, you can stroke it over. As long as you're moving, if you start really kind of poking it hard in one spot, that could cause a problem. But
the heat will get you.
All right. Well,
thanks
so much, Trey.
I hope it was helpful for you. I hope you have a great day and good start to your week.
Amen.
Appreciate you, man.
Thanks, my friend.
All right. Okay.
Bye.
Thanks. Bye.